Welcome everybody to this webinar. It's called Philosophy and Mental Health, and it's part of a series of events that feature in Philosophy Matters. Philosophy Matters is a new campaign by the British Philosophical Association trying to promote initiatives that give visibility to philosophy and the importance of philosophy for lots of different issues in our lives. So we're very happy to have a group of great panelists here today to discuss their work in mental health. A couple of things before we actually start. We'd like to thank also our sponsor, the Royal Institute of Philosophy, who is supporting our initiatives for Philosophy Matters. And EPIC, which is a project that we are all involved in today, chairs and speakers. And it's a 6-year project. The full title is Epistemic Injustice in Healthcare. It is funded by a Wellcome Discovery Award, and it is led by Professor Avi Carell at the University of Bristol. Okay, so I will let the speakers introduce themselves, but I wanted to say that they all have 2 things in common. So the first thing is, although they do philosophy and philosophy of great importance, none of them is based in a philosophy department. And I think that's beautiful. Actually, that shows that really philosophy is everywhere. Lots of them have philosophy background, of course, but they're working to embed philosophy in other aspects of our lives already. And the other thing that they have in common is that they are all contributors to this amazing book. And I say it's amazing because I edited, but it is actually amazing. And the best thing about it is that it's open access. So it's free to access. If you don't want this beautiful hard copy, you can just go to the website and we'll put the link in the chat and you can download all the chapters and see what you think. Not all the chapters of the book will be represented today. We're just giving you an overview of some of the themes that we are discussing in the book. And also what the speakers are going to do is move forward from those chapters and tell us what they're doing now, you know, what they are working on, which is related to the notion of epistemic injustice in mental health care. So that's my introduction. How this is going to work is that we will have short presentations by all panelists, and we will keep the questions and answer session for the end of the webinar. But if you have a question for one of the panelists or for more than one, at any point during the webinar, please put it in the Q&A box because we will get to them. And the other thing to mention is that this webinar is recorded. So if you lose your Wi-Fi or remember you've got something really important to do, don't panic. It will be on YouTube tomorrow. So you can catch up with what we're doing. And I just want to start by then welcoming Michael Larkin, who is our first speaker today, who is going to talk about what is done in the book and what is his interest in epistemic injustice.
Thank you. So I'm kind of doing a double act with Rose. We're going to talk about the same chapter from the book, and I'm going to talk about some of the background to it, and Rose is going to go a bit more into some of the evidence that we worked on. I'll just share my screen. That seems to be working. So our chapter is about the importance of feeling and being understood, and we're focused particularly in this work on young people who are seeking help with their mental health. And we've had 2 consecutive bits of funding from UKRI, and we call these 2 projects the agency projects. And in these projects, we've been working with young people to look at 2 kinds of data source. So we've been looking at real-life recordings of clinical interactions carried out at accident and emergency departments in hospitals in the UK, where young people were recorded during their assessment interviews, so where they were meeting with mental health professionals. And we've also carried out some interviews, retrospective interviews, where we asked young people in more specialist services about their experiences of finding their way to those services and what their experiences of help seeking were like, and what kinds of things characterized the important twists and turns in that journey. And one of the important things that we've been doing together as we've worked on that is we've been trying to develop a methodology for young people to work as co-analysts of these kinds of qualitative data. And so a lot of what we're working on at the moment is to do with how we describe that co-produced methodology for collaborating on qualitative research co-analysis. So that's where we're sort of headed with it. But what we're going to talk about today are the aspects of the project that are particularly to do with isolating the importance of feeling and being understood. And it's a really nice place to begin for the webinar because it's such a fundamental building block for thinking about epistemic injustice. So as you can see, our team is quite large and it includes lots of young people, and many of those young people have lived experience of seeking help and using services for mental health, and some of the adults do too. In terms of just having a beginning working definition of epistemic injustice, it's perhaps worth saying that it's something that goes wrong. And it's something that goes wrong when people act in prejudicial ways towards us on the basis of who we are or who they perceive us to be. So they might do that because we're young, because we have mental health difficulties, or because other aspects of our identities are held against us. And it's an injustice that's about knowledge. So we might be denied access to the resources we need to understand something, or our own understanding of something might be discounted as being valuable or insightful. And obviously, it's not the only kind of injustice that occurs or the only kind of injustice that we should be interested in. But underpinning a lot of this work is the idea that this is central and worth exploring and understanding better. Ooh, there we go. So one of the important contexts here is that young people experiencing mental health problems are encouraged by a whole range of public health campaigns to seek help and to talk about their difficulties. We say it's good to talk, don't suffer in silence, talk about your feelings. There is a general sense that we should be encouraging young people when they are in distress to talk about that distress to someone who can help. And what we would hope will happen when they do that is that they'll be met with empathy, with care, with curiosity, and with collaborative efforts to provide the right help and the right support. And these kinds of features would characterize what we would expect to see in a good supportive interaction, whether that is from a friend, a family member, a teacher, a mental health professional, whoever. We would hope that a good interaction has those kinds of qualities. And what we've seen on the agency projects when we've been looking at some of the specific interactions that do happen with mental health professionals in hospitals, and when we've been listening to what young people do tell us about their journeys towards getting the right help, is that actually it's very variable. It's really much more complex than that. And it really depends on where they go and from whom they seek help. It depends on the kinds of problems they disclose and how they disclose them. It depends on who they are and how their identity is perceived by the person that receives the disclosure. And in some situations, they may be listened to, understood, and then provided with support, as we would hope. But in others, they might be discounted and they might be turned away or denied help, full stop. And Rose is going to unpack some of those things as we move on to talk a little bit about some of the data in our work. Why does feeling understood matter? I'm going to talk about outcomes and then processes really briefly, just so that I can kind of hand over to Rose after that. It might seem like it's the wrong way around, but this was the way that made sense to me when I was putting the talk together. So outcomes first. It matters because disclosing distress is difficult. It's challenging. That's why we encourage people to do it. It's why we put so much effort into that public health work. And seeking help can be a difficult journey. The way that you find your route to the best help available to you can be complicated. And so young people seeking or receiving mental health care They tend to report that the really crucial factors here that carry them through are the therapeutic relationship and the trust that they develop with the person that they disclose to. These are really central because they're to be contrasted with shame and stigma. And I know that colleagues will be talking about stigma as the webinar goes on. A good response to our disclosure is going to encourage us to persist, even if the person can't help us right there and then. If they are sympathetic, if they listen, if they're curious, if they are willing to work with us to think about what could happen next, then you will persist. Ideally, the message you should come away with is that you've done the right thing and you've come to the right place. And so that's what we would be looking for to characterize a good interaction. But a poor response is going to encourage us to give up. When people feel that their needs and their feelings are not being properly understood by professionals, they will feel that there's a risk that this goes wrong, it goes badly. They might feel that the person isn't trustworthy. They might feel that future attempts to seek help are also unlikely to succeed. And then they may feel that they've wasted someone's time or wasted their own time. And that would be an outcome that we don't want. We don't want people to seek help and then feel, actually, this was a waste of time. We particularly don't want them to go away with an added burden of having felt that they've wasted someone else's time. That's awful. So we want people to feel that they have been understood and that they've done the right thing and they've gone to the right place. And there are other outcomes embedded in the process that gets you there. So one of the things we know about feeling understood is that it's associated with just generally doing well. The sense of felt understanding, when it's measured, is consistently associated with feeling connected to other people and with feelings of well-being. Conversely, when you feel that you're not understood, you're more likely to experience negative emotions and express poorer life satisfaction. We want to avoid injustice because that's the right thing to do. And to do that, we need to understand the context and the complexity of the challenges that people face. And if we try to take shortcuts when young people disclose their difficulties to us, then we risk treating them and their problems as types, as stereotypes or archetypes. And that means that we risk jumping to erroneous conclusions, that we dismiss people by saying, oh, this doesn't sound serious, or that we misread the context of implication that has been shared with us. So you've got someone at home to help you, so you don't need my help. These kinds of things are the kinds of things we've seen in our data. And finally, the last thing is, of course, that professionals who take time to understand may be more likely to be effective in then providing the right help and going on to develop a supportive relationship. So people who understand us are, just by common sense, going to be more likely to be able to respond to us with empathy, to earn our trust, and then to be able to help us. And these are the building blocks from which all of the outcomes of help seeking are reached. So it's a really kind of crucial early part of what happens when young people are seeking help. I will just quickly share this last slide, which has got a link to some information about the agency projects, and then I will hand over to Rose.
Thank you, Michael. Rose, over to you.
Thank you, Michael. I'm just going to share my screen, so just bear with me a second. Can you see my slides? Okay, can you see the title slide? Great. So I'm going to follow on from Michael, as we worked very closely, obviously together, as he mentioned, with Lisa and other members of the agency team. And I'm going to talk about communication in emergency departments or accident and emergency departments where people present in a mental health crisis. And Michael mentioned the agency team. This was the original team that we started off with, which then expanded. Sorry, I need to just find that. Oh, and this is the main paper we published that will describe some of the findings I'll talk about today. So I just want to mention that during this talk there are distressing topics and videos about suicide and self-harm. So please be aware that this will be coming up, and please, obviously the Samaritans in the UK are available, but please just feel free to leave the webinar or at any point in time. So we worked on with the core concept of epistemic injustice. and looking at kind of the concepts described by Fricker around testimonial injustice, where a person's reports are dismissed or challenged as a feature of their identity. And as Michael kind of discussed, this then can lead to kind of stereotyping people, thinking about people as types, and denying their credibility as knowers. And then, so for example, the idea that maybe a teenager's report that they're suicidal is kind of overly dramatic, or that, you know, young people are snowflakes and they don't really understand what they're talking about, so we don't take it seriously. Or hermeneutical injustice, where a person is denied the conceptual resources to understand their experience. So for example, for maybe women who live in a misogynistic society, they wouldn't necessarily have the concepts of sexual harassment or domestic abuse to understand their experiences as these kinds of experiences. So I'm going to talk about interaction and how we can see epistemic injustice in interaction. And I'm using a method called conversation analysis, which developed in sociology by primarily Sachs, Shegloff, and Jefferson in the States. And really, what kind of this method shows is that the organizational features of conversation provide for the routine displays of participants' understandings of one another. So when people talk about like not feeling accepted or believed or understood, we can look at interaction to see how these things are actually unfolding in interaction by the way in which we as speakers and listeners respond to each other in conversation. So that evidence is there in interaction. So the kind of idea is that talk and communication is not random, it's actually highly systematic. And we microanalyze both verbal and nonverbal features of interaction. So specifically, I'm going to focus on epistemics in interaction as it links to epistemic injustice. And epistemics in conversation analysis is concerned with how knowledge is claimed, contested, and negotiated. So in general, the thoughts, feelings, experiences, hopes, and expectations of persons are generally treated as theirs to know and describe in interaction. And this is a quote from John Heritage, who's written a lot on this topic in conversation analysis. And we know that speakers continually mark their levels of knowledge about a topic relative to one another. So for example, if I say, how are you feeling today, Lisa? I am marking a lower level of knowledge on the topic about how you're feeling than you. So we can see all of this play out in conversation. So in healthcare interactions then, patients typically have primary epistemic rights to know and report on their own experiences and symptoms. And then healthcare practitioners hold primary epistemic rights over diagnosis and recommended treatment. So epistemics are highly dynamic in interaction. They change from moment to moment, and they differ according to our role in the interaction. So if we think about mental health and kind of thinking about self-harm and suicide, there's no physical tests or investigations. So mental health practitioners rely heavily on communication to assess mental state, ask people about their moods, thoughts, feelings, behaviors, etc. We're looking here at suicidal ideation and self-harm, which is any act of intentional self-poisoning or self-injury, irrespective of the motivation or apparent purpose behind the act. So it can take many forms, including cutting, overdosing, banging, hitting, risky behaviors, etc. So what I'm going to focus on now is communication practices that have been identified in other settings that either seek or use evidence to undermine people's accounts. Questions that imply inconsistency or implausibility. So for example, a police officer might say, didn't you just say that you were at home that evening? So contesting people's versions or implying inconsistency. Questions that indicate objection or disagreement, but how could you have known that? And political discourse that contributors, these are often seen in like courtroom settings, police settings where there's kind of like some kind of interrogation or questioning going on, and they contribute to kind of an erasure or rewriting of a person's experience. So like recharacterizing what people are saying. So I mentioned that these are emergency departments, and the institutional agenda in these assessments is to assess suicide risk and needs for care, to decide whether it's safe for the person to be discharged, and to formulate a management plan. So practitioners are under a lot of pressure to discharge people within 4 hours of the time when they present to the front door, and that's after having gone through kind of had their medical needs seen to, etc. Mostly this target is probably not met. But it's important to also know that the practitioners, they're mostly nurses, mental health nurses do not do therapy. So I'm just briefly touching on the point that Michael mentioned as well, is that interactions with healthcare practitioners really shape people's perceptions of whether they need and deserve medical help or attention. So the idea of candidacy is important. And people in mental health describe a kind of a fear of being seen as faking it or just wanting attention as a barrier to mental health care. So we're looking at communication that maybe undermines or implies implausibility or recharacterizes people's experiences. And then by contrast, practices that accept people's accounts and experiences and also validate them. So we video recorded these assessments, and I won't go through the details of the group, but they're available in the paper if people want them. And what we found was that practitioners use specific communication practices to either recharacterize, downplay, and undermine patients' descriptions of their experiences. And not just that they did these one single practices, but that multiple communication practices built on each other over the course of an assessment, which would be typically lasting maybe 45 minutes, to support an alternative characterization of the person's experiences. And so that patients' primary epistemic rights to know and describe their subjective experience is undermined. And we know from accounts and interviews of people that this really impacts on disclosure, trust, and obviously the quality of the relationship which then influences other outcomes. So the first case I'm going to show you is a young man who's called Patrick. And he has been experiencing suicidal thoughts. He's a university student. He confirmed that he was feeling suicidal at the beginning of the assessment. I haven't shown this transcript. And he described feeling fearful that he would end his life if he left his flat. So the university counselling recommended that he attend the emergency department. And at the start of this video, he kind of sums it up and says that he feels miserable. So what we see is Patrick saying, so I feel like miserable kind of sums it up. Now, don't worry about all the kind of funny symbols and everything but we transcribed lots of detail about the interaction. So don't worry about that. I'll talk you through. So the practitioner says, and yet, so this is a contrasting formulation in your face, you know, when you're speaking, you've got a variation, haven't you, of your expression and you smile and things like that. So she does not accept his account that he feels miserable. So that's missing, markedly missing here. But she proposes an alternative characterization that recharacterize him as able to kind of give the impression that, you know, he's got variation in his face. So that isn't really consistent with feeling miserable. And the patient says quietly, yeah. And the practitioner says, so you have times when you clearly aren't miserable. The patient does not agree with this. You're sort of enjoying things, or you're able to give the impression that you're enjoying things. So here in line 10, the patient says, in overlap, which is the most minimal thing you can say in conversation, and it's not an agreement. So if the practitioner then takes this as evidence, he then proposes that, I see, so we could safely say, you know, you wouldn't end your life. And there's a long pause. So normally talk happens quite quickly within like milliseconds. So there's a long delay here where the patient doesn't respond. And the practitioner says, or something that would have, and the patient asks for clarification, what, tonight? Practitioner says, yeah. And the patient says, I wouldn't have ended it tonight. So then the practitioner says, you wouldn't have. You notice that he deletes tonight. So he takes this as evidence of you wouldn't have ended your life. Okay, so maybe there was a bit of miscommunication because they brought you here. And the patient has to push back against this, not accepting it, saying, no, I am, but I feel like I haven't done it yet. So the patient is pushing back strongly against the characterization that's being put forward here. So after the ED, the practitioners, across the assessment, the practitioners undermine the legitimacy of him seeking help. They interrogate him about why the university counsellors couldn't have reassured him, is what they said. And they recharacterize him as not always miserable and not suicidal. He was advised to visit a self-help website and continue the university counselling. Over the next months, he returned to the ED twice, once for suicidal ideation and once for an overdose with suicidal intent. And in his 3-month post-visit interview, he reported that he would not have gone to the ED again unless he was brought back by university counselling services. So as Michael said, what we know and what we've heard from the young people that we've worked with again and again is that when they have negative experiences, it really impacts on their help seeking when they then go into a crisis or the crisis maybe gets worse. And one of the things they said to us, well, actually, if the practitioners are saying this to you, maybe you think, actually, well, maybe there is nothing wrong with me. Maybe this is kind of normal and maybe this is the way I'm supposed to feel. So case 2 is a contrasting case, which is accepting and validating the person's distress. So Sarah is a young woman presenting after a suicide attempt, and she's just described having like rapid shifts in her mood. Not only accepting, so you see the explicit acceptance by the practitioner with yeah in line 7. She gives the person time to kind of to describe her experiences. The practitioner accepts again here in line 12 with yeah, and the practitioner kind of displays empathy, if you like, or there's different ways of characterizing this, but it sounds like it's quite exhausting because it must sound like you almost don't know where you are from day to day. And that encourages elaboration from the young person saying, I'm fighting every day myself and I'm so tired. So you can see that the accepting and validating leads to elaboration and a kind of a shared understanding about the experiences. So she described the assessment as really, really useful, particularly getting off her chest how she was feeling. She reported that she felt quite safe when she went home because of the good conversations that she had had with the practitioner. So the final case here is characterizing a suicide attempt as impulsive, which is something that's happens in various kind of settings in the UK, particularly with people who have the diagnosis of personality disorder or borderline personality disorder, which you may have come across. She was brought to the ED by ambulance after a serious overdose. She said that she had visited her general practitioner earlier in the day seeking help, but they didn't help her. She reported that she later took the overdose because she felt very suicidal, and she does not indicate that she took the overdose impulsively. So we get kind of questions that anticipate a compromising response, that imply inconsistency and implausibility, juxtapose, contrasting information, and then providing evidence of an alternative characterization. So I don't have permission to show the video, but this is the transcript. So we get the practitioner asking, and then what was the intention when you took the overdose? And the patient says to kill myself. Practitioner says to kill yourself. And then I hear that you call the ambulance straight away or 111. Patient says, no, I got on the phone with 111 and they got an ambulance. Practitioner says, for you. Patient says, for yeah. Practitioner says, so when you called 111, what were you expecting them to do? Patient says, all I expected them to get an ambulance out to me, to be honest. That's the way it works. Practitioner says, so would you say you took the tablets at the spur of the moment? Patient says, well, I took the tablets and then later on, I told them how many tablets I had. So the practitioner and the patient are speaking in overlap here. And when you see people in overlap, that's always a sign that there's some kind of conflict or misalignment going on. And obviously it's very obvious in an argument when people do that. But so the practitioner says, would you say you took the tablets at the spur of the moment thinking I want to end my life? And then you got worried that you wanted to die and then you called them. So you can see that the practitioner is proposing this characterization, but the patient is pushing back in overlap that's not accepting this account. So the practitioner said that they would get you the help. Is that how it worked? And the patient says, sort of, yeah, which is a very not an agreement. Practitioner says, yeah, okay. Patient says, I sort of wanted to die. Sort of didn't, because I have 2 kids to live for. And then the practitioner says, so it was more of an impulsive thing at the time. So later on in the assessment, the practitioner says, and the cocodamol, was it there for your pain, or why was it in your house? Patient says, well, originally I had it for pain relief. So she starts to question her about the medication that she took. But then I took a certain amount of it and I took an overdose. And then the practitioner asks, I see, and why didn't you take your other medication, which is a much stronger medication? And the patient says, because I didn't think it will have an effect. And then the patient says, the practitioner says, would you ask for help if those thoughts come again? Patient says, I might ring the response team to make sure I'm not taking overdoses. And the practitioner says in line 7, you want the rapid response team? Patient says, yeah, if there is any, well, practitioner says, well, we'll talk about that. And then later on says in line 13, I can appreciate that you feel this, but until Kate upset you, you've been coping generally okay. So you get this contrasting information that actually you're coping okay. This was impulsive. When you rang, you know, you took the overdose, but you immediately rang for help. So that suggests that you didn't really want to die. And then the practitioner says, and then this happened, and then this caused this impulsive behavior. So Laura never agrees with the characterization spur of the moment. Practitioner later asks her to confirm that it was an impulsive thing. Again, she doesn't accept this characterization. And in the discharge letter, to the GP and the team here write that Laura told us that she took the overdose impulsively because she was fed up with people picking on her. So which is not actually what she told them. She didn't say that she took the overdose impulsively. So just to summarize, what we're seeing then is that these practices don't acknowledge or accept the patient's account. They resist or directly question the account. They imply inconsistency or implausibility. So for example, didn't you tell your GP that you were coping okay? Or you called for help, even though you're telling us that you wanted to die. They embody a compromising response, something like, but you felt like this before and you got through it. And so again, and the last example, which I've just mentioned. So they are kind of the practices that we have identified in other settings. And these practices kind of, as I said, built on each other across the assessment, and they're used to justify decisions not to provide further support or referrals. So they're kind of used in gatekeeping, in a gatekeeping way. So I think probably in the interest of time, I should skip on and finish off, but saying that obviously practitioners are under a lot of stress in terms of follow-on care. So the very long waiting lists for care and specialist care cannot always be accessed. And also practitioners are fearful about discharging people who are considered high risk of self-harm, because some people who die by suicide the practitioner will then be called to the coroner's court where risk has been identified. So I'll just finish there in the interest of time, and obviously we can share links to the papers, etc. Thank you, Lisa.
Thank you so much, Rose. That was fantastic. So next one, because we've got a tight schedule. So over to you, Luigi.
Thank you, Lisa. And good afternoon, everybody. Preserving dignity in epistemic justice or injustice in palliative care for patients with a severe mental health problem or severe mental illness is the topic of what we wrote for this very important book as far as mental health care is concerned. And the starting point is that we are speaking about 200 million people affected by severe mental disorders, including schizophrenia spectrum disorders, bipolar disorders, plus 300 million people with the major depression. And one of the interesting problem that we have, interesting in terms of something that has not been taken into account in the last few years, is related to the physical problems, the physical health of patients with severe mental disorders. They are exposed to a lot of many different physical illnesses, including cancer and bacterial infections, HIV infection, cardiovascular diseases. And there is a big work done by the World Psychiatric Association within the working group, trying to understand how to deal with the problem of physical health care in patients with severe mental illnesses. We know that 1 out of 4 people can have a diagnosis of psychiatric disorders, and on the other side, we know that cancer is one of the most terrible diseases affecting a lot of people in the world. We have projections by the World Health Organization indicating that by 2050, there will be an increase in cancer diagnosis around the world, 70% increase, including mortality, with the need to improve the quality of care, of cancer care, but also the quality of end-of-life care, specifically palliative care. we try to understand a little bit more about this problem, and there is actually a big sector of mental health and psychiatry working in the setting of oncology, and this is psycho-oncology, but the problem of cancer and severe mental illness and serious mental disorders has not been examined in the last 25 years. So we dedicated a lot of effort in order to try to understand better, at the same time to create some kind of recommendation and guidelines to help both psychiatrists and oncologists in terms of the quality of care of patients with severe mental illness who develop cancer. When we speak about palliative care, we know that there are different issues that are actually related to the need for patients to die with dignity, to receive optimal care in terms of psychological and spiritual help, also in a way that the quality of life at the end of life can be considered part of a process, and in the most optimal way as it is for all the people in the general population. When we speak about patients with severe mental disorder, we find that is not the case at all. And we find, in contrast, that end-of-life care is lacking for patients for schizophrenia. This is one of the first studies, as you see, quite recent, done only 10 years ago. That is the first study trying to look at the problem of palliative care in patients with severe mental disorders, and that has been replicated in many other countries, including Europe and including Italy. Harvey Chochinov is the colleague with whom we are working a lot in the last 10 years, and who not only developed the dignity in care model, but also had the chance to understand a little bit better in Manitoba what is going on with patients with schizophrenia and bipolar disorders. The concept of dignity is really related to the concept of stigma, is the other side of the same coin, and is actually very much related to the concept of epistemic justice or epistemic injustice. Harvey Chochinov is used to say that psychiatry and palliative care as the two sides of the same coin, and this actually exactly what it happens when we try to work with people with severe mental illness, and it's quite clear that they are not understood, and that they are ignored when they speak about some possible physical problems, for example, pain. They are not actually believed in what they are feeling, and this is a problem not only in terms of having the risk to develop medical disorders, including cancer, but also in being treated in a dignitous way when they are at the end of life. Dignity is a broad concept, considered from the Renaissance time to the Kantian time to more recently as something related to ethical values, to the sense of self-respect, the respect for all others, the sense of self-belief, and the respect, autonomy, empowerment, communications are part of this very large concept that is really important to be taken and put into the medical system and the healthcare system in general, as it is for the aim that the Dignity in Care program has. The framework of dignity that can be used to understand a little bit better what it is and the way in which we can reorganize our healthcare system in terms of dignity has been considered consisting in three different big areas. One area relates to the concerns related to illness, the level of independence, and the symptom of distress, both from the existential and psychological and spiritual side, and the physical distress, but also everything related to what I've just said about the concept of dignity, the dignity conserving perspective, the sense of continuity of self, the raw preservation, the generativity legacy, the dignity conserving practice, and at the same time, from the relational point of view, the social, interpersonal, intersubjective part of dignity that has to do with the relationship between healthcare professionals and patients. And we have always to try to, in a parallel process, to understand what I'm saying with respect to patients with severe mental disorders. From the therapeutic implications, it's important to work in a way that not only through good communication skills and some kind of interventions related on empathy, active listening, a good relationship from the personal point of view, but also with some therapeutic tools, like, for example, dignity therapy, we can improve the level of dignity of our patients, at the end, the dignity and the level and the quality of our healthcare provision. We try to analyze in a little bit better way what dignity in medicine means in terms of definition, the way in which we can assess it, and the way in which we can intervene to increase the level of dignity. And here is exactly what we consider the double way to understand the problem of dignity and the problem of stigma, considering that both dignity and stigma have the same kind of characteristics in terms of the way in which each of us consider himself, the dignity in self, and the way in which other can consider us as people with value, dignity in relation. At the same time, we find the same characteristics in stigma, considering the self-stigma that people project inside themselves and the social stigma coming from the interpersonal relationship. Structural stigma and human dignity are two parts that are quite really related to epistemic justice, epistemic injustice. We try to work in terms of changing the healthcare system as much as possible, both at the hospital level, particularly hospice or palliative care, home palliative care system, but also at the level of primary care. And there are different models in which we are working in disseminating the dignity in care philosophy throughout the different settings of healthcare. As I say, not only hospital, but particularly the primary care system. In Italy, it's organized in a different way with respect to UK or other European countries. And there is a chance to work in a consultation liaison model, both collaborative care and proactive care from the hospital and the community healthcare system as provided by primary care physicians. That's something that has been written and elaborated a little bit more in the chapter, and I hope that this area related to psychiatry and mental health can be of interest to all of you. Thank you very much. Just the acknowledgements regarding EPIC, and I have to thank Lisa for that, but also our two projects from the Next Generation European Union in neuroscience and in psycho-oncology for our work in psychiatry as it is related to cancer and oncology in general.
Thank you very much, Luigi. That was really interesting. And you kept perfect time. So we can now have Rabi to present to us. Over to you, Rabi. Thank you.
Okay, thank you, Lisa. Just to share slides. So good evening to all of you, and thanks for the invitation to present this work. It is about promoting good living and social health in dementia. So just to say something about my background, so I am working in clinical psychology of aging, and during my research and academic work, the main focus is about aging, but also it's about dementia. And I'll try to describe you some work we already developed on the topic of dementia, and maybe to see the link which can be with the issue of epistemic injustice and how epistemic injustice is ongoing in the field of dementia. So first I will start from aging and ageism. Already my colleague Luigi Grassi talked about stigma, and the issue of stigma in aging and is really a big issue. It is also a recommendation from the General Assembly of the United Nations that it should be the first action to be undertaken at a world level in order to address this issue and to remove this, because it has a lot of implication for the well-being of older people, for their access to services, for receiving treatment, and also for social inclusion and social participation. And it really it's present not only at the community level, but also at norm and policies. And you can find it also in services and in healthcare system, where people, older people, are not treated as they should be treated and not recognized in their limits, but also in their capacities. But moving from the aging population, the focus will be on dementia. Why to talk about dementia now? Because the World Health Organization call dementia as a public health priority. It is related to the number of people affected by dementia, but it is also related to the fact that the aging population and the increase in age is related to to dementia, since age is one of the main risk factors for developing dementia. So it is expected to grow in the next years. And up now, we don't have a cure for dementia. Something is coming out, but we don't have a really cure for dementia. So it's really the approach to dementia should be addressed. On the other point regarding dementia, it is a neurodegenerative disease, which means that it affects capacities of people, mainly cognitive abilities and also functional abilities. So there is a progressive limitation. But one of the misunderstanding in this topic is that the focus is only on deficit rather than on capacity, because people with dementia don't lose all their capacities in different domains, but always we look to them that are without capacities. So it is a kind of extensive disability model approach to people with dementia. And this had really a huge impact on how we look to people with dementia. So the consequences of this way to look to dementia, to people with dementia or living with dementia, labeling dementia as a disease. So you can see the word demented or affected by dementia, and this has some consequences. We look to dementia, it is a burden for society, burden for family. Sometimes we say that people with dementia are dangerous for others, or they are old, weak, but also we consider them incompetent, unreliable, incapable, useless, and many other terms we can add. So the view to people with dementia is really negative, and we think that they are completely unable to interact and to be in relation with others. So Kate Swaffer, which is a person with dementia, she used this sentence that there is a systematic and gross underestimation of the capacity of all people with dementia, with any type of dementia and disability. So I would say they focus on the concept of ability, not only on disability. And looking to people with dementia from this point of view, from this perspective, so the issue of stigma become really an important aspect. Not only public stigma, but also internalized stigma or self-stigma, as it had been mentioned before, but also stigma affect family. So we can talk about courtesy or affiliate stigma. So also family member of people with dementia are in some way affected by this stigma. And also organizational stigma. For example, now there is a movement on how to work with hospital or with care setting in order to become dementia friendly. So to train and change in order to be able to accept and to treat and to deal with people with dementia. And what are the consequences of this? So people with dementia are avoided by friends, by neighbors. So they look to them that they are enabled, nothing to do with them. We cannot interact, we cannot do something with them. So they are kept away from social contacts. The issue of diagnosis disclosure, I will come back to this point because it is important, but also they are not involved in the choice of treatment or intervention. Intervention are mainly focused on treating dementia, non-treating or involving people with dementia. Also, the issue of decision making is affected, I would say, by this perspective. And also, they don't decide where they want to live. Someone else decide for them where to live. So, Don Brockle used the term dementeism. So, not only ageism has its impact on people with dementia, but also the dementia itself. It is another stigma. So they have a double stigma in some way. So if you look to diagnosis disclosure, there is a lot of data and research, and we do something about this. And there are differences between countries. So in Europe, across Europe, there are a lot of differences between countries, but always people with dementia don't receive information about their diagnosis. So they go to the visit to the memory clinics, but always the diagnosis is communicated to their family member, to their caregivers, but they don't receive any communication about. And when we ask a professional why people with dementia, or when we ask caregiver also why they don't want them to receive the information about their condition, about their situation. So one of the most item repeated is that they are unable to understand. Keep in mind that diagnosis is made at the early stage of dementia, so people have a lot of capacities to understand, to speak, to describe their condition, but others say they are unable to understand, or they are forgetful, so they will not remember their diagnosis, or they are not aware of what's happening to them. But when we talk with people with dementia, they say, I want to know why I don't remember name, why I don't know how to move in the space around me, I got lost last time. So they are aware, but they don't receive any information about their condition. Also, they are fear because they are considering them that they are weak, so they will be sad. So they don't want to, how you say, to put them in this condition. But also there are caregivers themselves that they don't want that people with dementia receive the diagnosis. So the concept, the point of diagnosis disclosure is around the view by family caregiver and by professional that people with dementia are unable. So it is a right, they should receive their diagnosis, but it is not done with them by others. So this is one of the views that others have of people with dementia. The second point we work on is about the issue of advanced care planning. Maybe you should know that advanced care planning should be done at the time of diagnosis disclosure, so people know what is their condition, and then we have to plan with them, and all healthcare professionals should undergo a care planning. And in Italy, it become mandatory, but I think also in many other countries, it's mandatory to the issue of advanced care planning. But also in this aspects, we do interview with people with dementia, with elders, or also people in home setting and in a nursing home setting, and staff say that are unable to understand, they are unable to make a choice about. So it is really important to consider, for example, in this, what kind of choice should they take, about what decisions should people with dementia takes. So it is really important, this aspect. Another point is the confusion. So even if verbal communication can be limited in people with dementia, but non-verbal communication is still available, and people don't look to this, don't take into consideration the how you say the opportunities of communication, the large opportunities of communication, and so they avoid in some way interacting and communicating with people with dementia. Of course, the severity of limitation can influence the capacity of people to take part in an advanced care planning, but not on all aspects, not on all issue in advanced care planning. Maybe for medication, that can be some limitation, but in activities they want to participate or they don't want to participate, maybe they can express their idea by accepting or by refusing these aspects. And mainly one of the main barriers of this is the attitudes of the staff. It's not coming from people with dementia, but the attitudes of the staff. Sometimes older people, not with dementia, say, we don't have anyone to talk about with him. So staff avoid talking with people about or addressing this issue with older pupils. Another issue related to this aspects of people with dementia is the shared decision making. We do a lot of work about trying to understand what are barriers and what are facilitators related to shared decision making with people with dementia. And again, it is professional attitudes and the training of professional in communication skills and in capacities to listen to people with dementia, to understand what are preference, what are wishes of people with dementia, even if they are in moderate and severe stage, but also family attitudes. So there is a kind of alliance between family caregivers and professional in order to exclude, to put out the people with dementia from interaction and from decision, but also organizational aspects, allowing time to do it, having time to do it, having resources to do it. It is also a kind of barriers. So what is from the interaction of the relationship, one of the main barrier is the recognition of the ability to communicate. And here it comes back again, the issue that people with dementia are unable. So they don't make any effort to change way of communication, but just they label the person with dementia as unable to communicate with them. So really, it is also here in a kind of extensive disability again, where if he has some limitations, so they are an overall limitation, and he is not involved in any type of decision on this point. Another aspect I want to address about this issue, how people with dementia are approached. There is the topic of behavior, I would say, because in medical literature, in psychogeriatric literature, there is the level of the category of behavioral and psychological symptoms of dementia. No, but it is a way to pathologize behavior. I don't know if behavior can be seen always as a pathology or as a symptom of the disease, or it is a way of communication of people with dementia. Since the imbalance between verbal and non-verbal communication lead people with dementia to use their abilities. So maybe they don't have very adequate verbal abilities, so they can use the non-verbal language, both body language, but also voice language and any other type of language to express their difficulties, to express distress, but also to express need or to meet their needs, or in some way to participate, to interact with others. But all this behavior is labeled as symptoms. And if it is labeled as symptoms, so this means that the person with dementia is not acting, so the agency of the person with dementia is not considered. So it is not an expression of the person, it is not only an expression of the disease. And this really limit the possibility to understand people with dementia, to interact with people with dementia, to meet, to allow them to meet their needs in some way, and to not be excluded and limited, and maybe sometime they use sometime also pharmacological intervention in order to control behavior from this way. So it is completely ununderstood the behavior of people with dementia, because it is not, they are not behaving as usual, they are behaving in another way in consideration to their limitation and to their capacities. So if we don't take into account capacities of people with dementia, if we don't take into account their abilities to interact, their needs also, so really it is difficult to support them in living well. So what we focus on is the issue of good living, what we can mean by good living, and what we can ensure a good living for people with dementia. Of course, they have a limitation, a big limitation. It is a really serious illness in some way, but we can do in some way to promote and to support their autonomy and their independence. We can support them to keep an emotional balance, to support self and identity, because, for example, memories and biographical memories are really important for people with dementia, and we can stimulate the recalling of old memories, and this can support self and identity of people with dementia. But also, as we see, family caregiver are one of the main support, but also barriers. And so we can work on the close relationship between people with dementia and their caregivers, because that research outlines that a good relationship, it's really important and its impact not only on the progression of the disease, but also on disability. But there is also the topic of social participation, social connectedness, and social engagement of people with dementia. So for this reason, or for this aspects, we work a lot with European group, Interdem group. We work together in order to try to develop the concept of social health, focusing on the issue of dementia, because it is also mentioned in the definition of health, no, physical, psychological, and social. But we try to operationalize this definition and try to see how it can be used, how it can be applied in order to promote good living of people with dementia, because it is, as we see before, it is on an individual level and also on a social and environmental level. And what we focus on, and what it come up from research, is that social health is a dynamic process between person himself and social environment. First, I talk about self-stigma and public stigma. It is not separate, it is interacting. It is really a dynamic process. And also in this point, it is a dynamic process. So we can support the person to be engaged, but also we can develop context, social context, that allow people to be engaged. So we can support people with independence and autonomy, but we can also develop context, we say friendly communities, where people with dementia, even if they have limitations, they can be able to interact and to participate in social activities. So it is really a reciprocal interplay, and for this we use the term psychosocial. So we have to work at the individual level and also at the social level in order to give the opportunity for people with dementia to still living and to have a good living in our society. So all this research I had done in the past years, and it come, I think, to the concept of epistemic injustice. So we have to move from all about us without us, maybe to what the Dementia Alliance International say, nothing about us without us. So this, so we have to move from this. And I think from what I described until now, that epistemic injustice in dementia, it is both testimonial and the other type. So really, the person with dementia is unreliable as partner in care. So he is not heard. No one give importance or give a sense or a significance to what they say, how they behave also. So it is really absent from the interaction. So no one consider him. But also, on the other hand, the perspective of the person living with dementia is not considered and valued. So how you can say, really it is a double injustice here from way. So he is not considered, but also he is not valued as a person who can have a role, a part in our society, in our context. And this is we move in. How we say, I think the link between what we do and the concept of epistemic injustice, and we are going now to explore it in detail, using interview with people with dementia to understand well what is their experience, what is their point of view about this issue. So really we need to reframe the narrative, the portrayal about dementia in research, in policy, in care, and in community. So we really need to change the view, the perspective about this, and also to recognize the dynamic process. So it is not the matter of the person himself, it is not the matter of the community, it is really a dynamic process. Thank you for your attention.
Thank you so much, Ravi. That was great. So we got to our last presentation. So Elisabetta, over to you.
Okay, so first of all, thank you so much for having me here. I'm really happy to be here at the Philosophy Matters webinar. And so thank you for the invitation. I might be sharing now, maybe. Yes, sorry. Am I sharing?
It's perfect.
Okay, good. Yeah, so I unlike my colleagues before me, I'm just a philosopher. I'm not a psychologist, so I don't have any qualitative research to present you. But I am currently working on 3 projects. One is Project Epic, together with the people who spoke before me, but also on 2 other projects. One is about digital lifelong prevention. So in bringing together projects of digital health in Italy. And the other project is about shared decision-making in advanced breast cancer. And both these two other projects are, well, they do involve digital technologies and digital technologies in support of healthcare, even if it's not mental healthcare. So, so my curiosity, my interest, my research interest is currently to try to understand whether digital technologies in healthcare, and especially in mental healthcare, can be tools for ameliorating epistemic injustice. And well, the consensus seems to be that, in fact, they are bad for people's voices, and usually they are like something that makes epistemic injustice worse. So my tentative aim today is to show that there might be some other way to think about these situations. So, well, you all know what is epistemic injustice, and epistemic injustice in mental health care is something that can can be seen, can be articulated at least in these two ways. There's testimonial injustice when someone's word is discredited because of prejudice, and there's also hermeneutical injustice or interpretative injustice when someone lacks the conceptual resources to make sense of what they're experiencing. And both types are common, as you know, in mental health care. For example, people with diagnosis or with conditions may not be believed when they describe how they feel, and people who are neurodivergent, so people who have not accessed an official diagnosis, may not have access to the language that would help them explain what they're going through. Sorry, and yep. So, and you know that these two aspects are not just individual issues, they are structural issues because they're built into the systems of care and the ways of thinking of people. That's why we need, you know, these big project interventions to make a difference on them. So what about digital phenotyping, which is the technology I'm talking about today? Digital phenotyping, well, it's more of a promise at the moment. It's not really used that much, but it's the idea of using data from, let's say, smartphones, wearables, data like movement, speech, screen time, and social media behavior and time in order to track behavioral patterns, and so to detect early signs of mental health conditions, or also, well, signs of recovery or monitoring one's own condition. So it might have, you know, great potential for ecological, personalized, real-time insights on what happens to people. But it is also, let's say, a double-edged sword, meaning that used poorly, it can really override patients' voices and create new forms of epistemic injustice, especially if the outputs of these systems are treated as more reliable than what the patients say. And as you all know, there also the problem of the quality of data and of the opacity of algorithms and possible biases that are built into the algorithms. But let's say, abstract from the problem of the quality of data for the sake of the argument, and let me explore just the theoretical possibility of having a good use of these kind of technologies. Here's a fictional case, fictional case like that I built from readings about, you know, women high functioning ADHD symptoms. So it's a case of misdiagnosis, bias, and let's say redemption. So this character, let me call her Anna, is a successful academic in her late, let's say, 30s, and over time she begins to suspect that she may have ADHD, and so she struggles with, you know, focus, task switching, time management, you know, executive function problems, especially when she's not under pressure. She can't concentrate, whereas she concentrates only when she is under pressure, and also she has a lot of, you know, episodes of impulsive kind of behaviors. And so she reads about ADHD, and she starts to strongly relate to the possibility of having this kind of diagnosis. And she brings this up with her psychiatrist. But the response is very dismissive, and the psychiatrist says, well, ADHD is a childhood disorder. You should, well, I mean, it's, you don't meet the conditions. People like you're like too successful, and, you know, you're functioning. You don't have it. you're just too stressed. You're just, and this might be a case of, testimonial injustice, because Anna's self-understanding is discredited because of who she is, and because of not being able to capture the experiences of this specific kind of population of people with, let's say, high-functioning adult ADHD. But then she decides to bring her data to let's say to another clinician, and the data show clear signs of attention irregularities and bouts of iPhone use and on social media, and then inactivity, and then shopping, impulsive shopping and stuff, consistent with her hypothesis of ADHD. And in this time, when she brings this to a new clinician, the response is different, and she's taken seriously. She's referred for assessment, and then she gets her diagnosis that she wanted to, right? She wanted to get this. So this is not a miracle of technology, of course. It's a case of someone, let's say, regaining epistemic agency with the help of a tool that made her perspective somehow more visible. So sometimes when we philosophers talk about epistemic injustice, we also use the concept of epistemic rigidity in inflexibility in healthcare, meaning that just one kind of evidence is usually taken seriously. The biomedical kind of evidence, what can be measured and what can be, let's say, translated into the doctor's vocabulary, into the medical vocabulary. And maybe in this case, epistemic rigidity of healthcare has become an ally, because in Anna's case, the digital system was rigid. It applied the same behavioral criteria to everyone without bias. And unlike the human psychiatrist, it didn't carry any assumptions based on, let's say, gender, class, or diagnosis. So even though the digital system can lack nuance, then sometimes their impartiality, if it is impartial, this kind of impartiality can counterbalance human bias. But of course, this is not always true. These systems are only as good as the data and the design that underpin them. And we know that biases can be baked into algorithms too, of course. So this is not a general solution. It's a reminder that epistemic injustice is context sensitive, and our tools might have unexpected effects. So the real danger is when digital technologies are granted absolute epistemic priority. Sorry for the philosophical jargon, but means that the danger is when clinicians or institutions treat algorithmic outputs as more trustworthy than human testimony, especially more trustworthy than the patient's own voice. So imagine someone is flagged as high suicide risk because of an algorithm, and then they say, I just feel fine. What happens if they're hospitalized against their will, which is the opposite of the case we saw at the beginning of our seminar today. So the point is about, so this would be a new form of testimonial injustice, not driven by stigma, by the assumption that machines are better knowers than people. But this is a risk that medicine in general runs whenever a new medical technology is introduced. For example, imaging technologies or new lab technologies. Medicine always runs the risk of trusting machines more than people. So there's nothing in this sense. There's nothing so special about digital health technology. Is a problem that medicine has to face. So when we stop trusting patients and start trusting data or machines exclusively, then we silence people in a new way. So, so can digital technologies help? Yes, but only under certain conditions. There should be co-design with users. People with lived experience of mental conditions or neurodivergence also should be involved in designing the tools that affect them. And this might reduce hermeneutical marginalization and might build trust. That should be support for self-interpretation, because tools should be such that they should leave space for users to reflect on and describe their data. This respects users as knowers of their own experience. And then finally, humans and AI should collaborate and should not be replacement. And that requires a lot of work in some sense. So that was all for today. I just wanted to present you with maybe a problem and maybe a challenge about the possibility of reconciling epistemic justice and, let's say, a wise use of new digital technologies in healthcare and in mental health care in particular. And thank you.
Thank you so much, Elisabetta. That was wonderful. So we have got to the end of our presentations. So if you've got any questions for the panelists, please drop them in the Q&A box. But I just wanted to start with a question for everybody or anybody who would like to answer. So I've noticed, and you know, that is very evident in the book as well, but I've noticed in the presentations today that a lot of interesting research, both conceptual and empirical, has been done using constructs that are different, right, from epistemic injustice, and in many ways they precede the application of epistemic injustice to healthcare. For instance, the concept of trust, the concept of epistemic right that Rose was talking about, of course, the concept of dignity that Luigi was talking about, and in Rabi's presentation we saw this idea of social health, and of course a stigma that is coming up in all of our presentations. So I guess what I'm asking is this, just imagining that I'm someone a little bit skeptical of epistemic injustice. Do we need epistemic injustice? Don't we have already the kind of tools that are available, given our previous research, to try and analyze what is happening now? What is it that epistemic injustice is bringing in that was not already there? Or what is it that is pointing attention to that is a little bit different or distinctive? So for anybody who'd like to answer this.
I mean, I'm happy to just begin with a reflection. So a paper I published fairly early on in my academic career was about consent in psychiatric hospitals. And a bit of data in that paper has always kind of stuck with me. And it's an excerpt where a young man is talking about an incident where he hit one of the doctors. And he's trying to explain that he hit the doctor because he was angry, but that subsequently in his interactions with other doctors, his purchase on that explanation keeps getting kind of further and further away. So the first doctor says, I think you were delusional, not angry. And the second doctor then says, actually, I think you've got schizophrenia. And so the distance between him and the explanation for the event gets further and further away. And he wants to say, whether I was delusional or not, the reason I hit it was because I was angry. And I suppose at the time we talked about that data in terms of a fairly kind of loose idea about warranting voice, about his status as a patient somehow not giving him access to the explanation that was seen to warrant voice in the environment. And it seems, with retrospect, that epistemic injustice would have been a really helpful and more precise tool for thinking about what was happening in that in that incident. And so for me, one of the things I like about it is the precision. It isn't, as I said right at the beginning, it isn't necessarily the only way I'd want to talk about injustices or failures of communication or distrust, but I think it's got a really nice grip on something that is a real tangible problem for us.
Yeah, that's great. Thank you. Anybody else?
Happy to follow on from that a bit. I think I do agree with Michael, and I think adding the injustice is quite important, because I think what we know from kind of working with people with, you know, a lot of many experiences of being in the mental health system. And this isn't just, you know, people who are suicidal or with self-harm, it's people with psychosis, it's people with lots and lots of different kind of symptoms. It's relevant to people with pain. You know, it's relevant across a number of different areas, but it's the idea that it's like that people know and feel it when it happens, but being able to kind of put a precise term on it really kind of reinforces, and I guess the definition of the concept is really helpful when you're looking at communication and being able to think about kind of like where are the moments might this be happening, and linking it with the kind of being able to see how people handle and kind of display epistemic stance in conversation. So pairing them together is really helpful, because we know that people talk about like the key role of trust, relationships, and how that's the most important outcome for people in mental health services. But it's not the most important outcome often in terms of research studies, but it is for people who receive treatment. So it's kind of giving us like some more tools to kind of maybe pick this apart and see how it actually happens in practice.
Thank you, Rose. Luigi?
Well, I just want to echo what Michael and Rose said. That is actually something quite common in the mental health arena, in terms not only for very severe psychiatric disorders, in terms of you are delusional, you are not delusional, you are really hearing voices or not, but it's something really related to the whole field of mental health or psychological issues, like, for example, a patient saying something about a somatic disorder, and the response can be like, it's all in your mind, and I don't believe you. And this is not actually possible. I feel this kind of side effects of drugs. Well, it's actually not really possible. So it's a kind of circular way in all the fields, in all the disorders, just because it is in your mind and is something related to your imagination, and by definition not true. So I can consider that epistemic justice, and I have to thank Lisa for involving me in the project and helping me to understand a little bit more about these different facets of the same, sphere, we can say. It's a way to rolling around and seeing different perspectives. And when we were speaking before the starting of the webinar with Michael, maybe that could be nice to try to see if it's possible to develop some kind of tool that can be useful with respect, for example, the concept of dignity. We have the patient dignity inventory, or for the problem of how to measure stigma, and we have some kind of tools to measure stigma, and maybe we can add something more that can be useful both in terms of clinical issues and in terms of training, mental health professionals, nurses, psychiatrists, general practitioners, etc., etc. Thank you.
Thanks, Luigi. Elisabetta?
Yes, thank you. So here's my very down-to-earth way to present the concept of epistemic injustice when I introduce it to first year medical students. So there's all the nice definitions and what you've just illustrated, but also there's this, this fact that when you treat someone that is an expert on something as a non-knower, a non-expert, you just lose information. It's just unwise because you're, as a doctor, as a clinician, you are in the position to, gather information. The aim is to arrive at, a diagnosis, at understanding, and then you see, if you commit epistemic injustice, it's not that you're just, not being nice, but you're throwing away valuable information from someone because of a prejudice. So it's a mistake, not just not being nice. And I think this adds up, a sort of selfish kind of aspect to epistemic justice. I mean, it is. There's an epistemic loss and there's an epistemic gain in being just.
Yes, I love that. I think that, there is something that you're losing when you're not listening. There is knowledge that you no longer have access to. So I think that's really important. Rabi.
I think that if we take the epistemic injustice, if we look at, for me, at least from my point of view, the word injustice, it is important to keep in mind. Because one, at least working with older people and with people with dementia, the issue of rights of people can help us to bring it up, the rights of people. For example, the issue of self-determination of people. I think it can help to, how you say, it's a kind of moving on beyond the stigma, because of sure, epistemic injustice and stigma are overlapping, but it helped to move on and to look to person, rights of person, agency, self-determination, some issue related to really to these aspects.
Thank you so much, Rose.
I was just going to add, Lisa, that I think there's a couple of points that so Luigi mentioned around kind of in mental health, where we're talking about like subjective experiences rather than physical experiences, maybe in other kind of domains of healthcare, but also where you've got like power imbalances in an interaction. I think epistemic injustice is particularly vulnerable. So, and I think you often hear this from young people as well, for example, in schools, for example, about, not being believed by a teacher, or, when they weren't in the wrong, but they've received a punishment or something like that. So I think there's loads of places that this, is really important, but where the power dynamic, and particularly, we're in mental health with, mental health professionals and a person in distress, where, the power to diagnose and to treat against somebody's will as well is there. It's quite an unusual kind of configuration of factors, which makes it particularly kind of important and interesting.
Thank you, Rose. That's great. Let's get some questions from our participants. And one question that we received, again, open to anybody to respond, is, okay, so we have established that there are these issues. How can we go about changing society? Actually, that's what our participant says. What can we do to improve the situation? $1 million.
That's a really big question, isn't it?
Yeah.
And so, I mean, I can offer some reflections, and hopefully that will buy someone else some time to say something cleverer. So I think one of the things that is challenging about that is that society isn't a single thing, that it's complex and it's dynamic. And even on things that we think are fairly straightforward, there's huge changeability and differences within however you've structured your society. So this morning I was speaking with one of our doctoral researchers about a piece of work that she's been doing just to see what people think social media is. So just asking people which platforms are social media and which are not. And there's huge generational differences in terms of how people describe what they think a social media platform is. So when we're in the wider discourse of having conversations about whether social media is good or bad for us, or in what ways we're using it and so on, we're actually all talking about quite different things. We're not talking about the same platforms, the same behaviors, or the same activities. And I suppose the same issue is relevant here, that there isn't a single predominant discourse. That the example in the question is to do with autism, and of course one of the things that has been a tremendous change in the last 10 to 20 years is that there is an autistic community that is kind of doing its own research to very high standards, that is providing advocacy and positive ways of thinking about what it means to be autistic, and that's a tremendous shift that wasn't there when I was in my 20s and 30s. You know, it was not so easy to see that as a way of making sense of what autism is, that I could perhaps draw on, or that my family might draw on to make sense of a family member who's autistic. So I think we when we're looking for change, we look to those communities to provide those spaces, and if they don't exist, we have to work together to create them and create discursive resources that people can use that provide positive framing. And then we have to work to get those resources out there and used more widely. And it's a dynamic process.
Thank you, Michael. Rabi?
Sorry, I'm in line with Michael. I would say two points that are important. It is our experience also working with dementia. First, we have to change narrative about dementia or about disease. It is important. So we have to see, we have to talk about persons, not about disease. And it is regarding professional, because always we talk about disease and this. And the second point, it is in line also with Michael. I think the next webinar, if we talk about dementia, we should have a people with dementia who talk about. So we have to involve them to give them the voice. And I think this can change, because in my experience in some conference, when we invite a person with dementia to talk, it's really changed. If I talk only me about as an expert, it is not the same impact. So, and this means we have to trust them that they can contribute. We don't have to only do things for them, but we have also to work with them and to trust them and giving them the voice. I think this is important if we want to change something.
Yeah, that's an excellent point. And I'm very happy that actually in the book, we managed to involve quite a lot of people with lived experience as authors of chapters and contribute to the research that we're doing, not just kind of consulting them, but actually getting them to do the analysis of the data to kind of promote the results, disseminate the results, and present with us at conferences. And it does change, and it does change the way we speak to each other and the kind of things that we say as well. Luigi, did you have a point on this one?
Well, yes, in the sense that what Rabi said regarding people with dementia invited to conferences and so on is quite similar to what it happens when you ask people with mental disorders to speak and to share their own experience, and in a way that is actually really related to narrative medicine. In a way, things can change, and this kind of peer-to-peer supervision, and having, for example, patients helping other patients to help them in trying to communicate in a different way in order to be believed, is quite interesting, and it's changed a lot also the stigma around mental disorders. So that's really important to have people involved in that kind of disease speaking about their subjective experience. That's usually, you know, the balance between objectivity and subjectivity, between disease and illness, between narration about yourself, and at the same time what practically can be done by doctors in reducing the symptoms, you know, like burning down a fire and nothing else. That's quite a problem, but it's the right direction. I like that a lot.
Thank you, Luigi. Elisabetta, do you think that digital tools will actually be able to contribute to changing certain types of perception in society?
Well, we panelists, we are like not maybe, we don't live on live completely, because we are, I guess, all of you like older than 25-year-olds, but people who are who are younger do live a lot into their smartphones, into their online world, and so to us is something that is something that gets added to our normal instruments and life, and for them is something very natural, and so I mean it's their natural environment to some extent, and so later these instruments will become more and more important as time goes on. So now it would be for some people it's like would be too difficult to approach their condition with another task, meaning, for example, learning how to use an app, because it's not health literacy, digital literacy is very different from age to age. But I can imagine, I mean, myself in 10 years or even more, my daughter, who is now 20, in 50 years, she would be completely at ease with an app and with a digital tool. So in the future, we would see these things as less strange and more, inside people's lives. That's why we need to understand how what potentials they have, and not just to see them as like devils or evil. I mean, limitations are evident and risks are evident, and also as whenever medicine relies on technology, then there's the danger of losing some slice of humanity, some parts of humanity. But then we need to tame the technology so that it helps. And yeah, I mean, that's very abstract, but it's what I think about this very huge topic.
Sorry about the question, it's very big. I have a question for Rose. So whenever I write about these issues, one very common response that I get is from unfriendly reviewers. Okay, reviewer 2, the famous reviewer 2. Yeah, reviewer 2 type person is, but isn't this just a question of communication? Isn't this just a problem of communication? And my kind of response is, oh, maybe, maybe if we start by changing the style of communication, we've already achieved a lot. So I wonder what you think about this kind of reaction, whether it happens to you as well.
I don't think it's just about communication. I think the issues that are kind of driving it are manifested in communication and displayed in communication. So I think, for example, what's driving it is often attitudes towards people and presentations, and also thresholds in various settings about like how ill you need to be, for example, to access care, and whether the legitimacy of presentation. So I think legitimacy is a big issue in terms of whether this person should be showing up here. But interestingly, and then the next thing is it has a real impact on the information that goes into the medical notes about that person, that's passed on to other professionals, and in terms of making decisions about whether or not they can access further care and support. And what you will remember, and Michael will remember as well from the conversations we had with the young people, is that so we're almost seeing it kind of being used to justify not providing further support and care. There's like retrofitted, if you like. But what people are saying is they understand that like health services are really stretched, but they'd much rather people say, look, I understand that you're having a really difficult time and it might be really difficult to access care, but they'd much rather that honesty, because they understand that you can't necessarily access all the care that you need, and there's a waiting list, etc. So it's not just communication. I think it's a manifestation of a number of different kind of other things, like negative attitudes, stigma, stereotypes about certain groups, particular people with particular mental health issues, particularly in our studies, people with a diagnosis of personality disorder who are heavily kind of stigmatized against. So I think it does have real impact on, you know, care and on the care that people get and on their health outcomes then eventually, if that makes sense.
Yes, thank you very much, Rose. A question for Jodie. Sorry to bring you in, but we've seen both in Michael and Rose's presentation and in Rabi's presentation that age seems to be a very important factor. And so we've got specific negative stereotypes associated with young people and negative stereotypes associated with old people. And I know that you're very interested in the intersectional aspects of epistemic injustice. So I was just wondering whether you could share with us your view of what intersectionality means in this kind of field and why we should study it.
Yeah, that's a really good question. So my kind of like understanding or particular take on intersectionality is that different facets of our identity can interact in really unpredictable and kind of chaotic ways. One way in which it's kind of been understood in the literature that's kind of been criticized is this idea of if you have several marginalized identities, so if you belong to a kind of marginalized gender, marginalized race, one take is that these things compound and therefore you face discrimination on multiple fronts. And there's a really interesting paper that I've been thinking a lot about, and I'm bringing it into our kind of empirical case study with the young people with psychosis. And it's this idea of sometimes it doesn't interact in a straightforwardly, like it just gets worse and worse and worse and worse, but they interact in like really unusual ways. So there's an example that I've been giving when talking about this of like old women who go shoplifting and how there's an interesting interaction there between like being like classified as a criminal, but also being an older woman, and how being a woman kind of like leads to a lot of marginalization. So does being older, so does being a criminal. But the combination of these things actually gives old women who decide to go shoplifting maybe a kind of epistemic benefit, because they're not seen to, these aren't categories that are typically seen to overlap. When you like think of the typical like shoplifter, you don't think of your grandma, a sweet old lady, and so it allows them to fly under the radar. So when it comes to the intersectionality of like young people and young people with a specific mental health problem, I'm kind of interested in like how do they interact in these like really kind of like chaotic and like unexpected ways? Where might they interact such that it makes certain things harder because these multiple factors are in play, but where might they interact in a way that is kind of like unexpectedly like maybe joyful? There may be potentially joy in being a young person with psychosis, for instance, because of the access to particular kinds of things like online communities that being young puts you in the room for. So that's kind of like where I understand intersectionality is we've got these multiple facets of identity, they combine and clash together in these really weird and interesting ways. And that makes an interesting place to then talk about epistemic injustice and like how it can come about from like the interaction of different factors in combination, not just like discrimination based on like one facet of your identity.
Thank you so much, Jodie. We've got lots of different questions and some of these have been answered already in the box, but there was something from John O'Donoghue was saying, as a mental health professional, I sometimes experience clients that have a particular view of how their healthcare should proceed, usually based on their own research and other people's positive access of healthcare. A problem is that the expert opinion can clash between the desired pathway of the patient, so with the desired pathway of the patient, resulting in a power struggle and consequently in poor mental health. This can also be challenging nowadays in employment situations where employers have their own pathways of support in the case where there is workplace stress. This might involve directing the employee to a doctor of the employer's choosing. The added problem is that it can be hard for doctors nowadays to be apolitical because they want to support the patient even though they're paid by the company. So this is, it says just a comment, less of a question, and he's thanking us for the discussion. But I wonder whether anybody else wanted to comment on these potential clashes that sometimes there are in the clinical context.
I guess I could say something on that, Lisa, because we have looked at kind of a range of consultations across primary care, secondary care, with a range of kind of issues like depression, psychosis, dementia, kind of et cetera, et cetera. So I think what we often see, and I did post something in the chat, John, that if we analyze the communication that goes on, what we see is that there's a strong correlation between if the healthcare professional really tunes into what the patient or the person is describing as the issue, and there's a shared understanding about that, and they use the same language and the same terminology, the person is much more likely to agree with the pathway or the suggested treatment or the recommendation. So often there's a kind of a clash in the understandings, but also if, as you said, people are becoming much more informed and they have much more stronger ideas and expectations about what they might expect or what they might think they need, like it's always about kind of eliciting, like exploring the person's ideas and reasons for that and working with that rather than trying to move over, because then you start to see a lot more kind of disagreement and kind of more clashes. So yeah, we've been looking at kind of like shared understanding is pretty important there.
Thank you so much, Rose. We've got also another comment from Felipe Santaella. I am hoping I'm pronouncing correctly. Very thankful for the webinar. He's a Brazilian psychiatry resident. And he says, I believe we should be talking more about epistemic injustice, especially from a decolonial perspective. It's not just about giving people a voice, but about paying attention to those who are not at the center of the conversation. I don't know whether anybody wants to comment or...
I'm happy to jump in while other people are thinking, but I think that's absolutely true. I think that's bang on, because I think a number of the cases that we've kind of talked about today are people with severe mental illness, people with dementia who are kind of, you know, kind of become kind of not part, you know, they become increasingly kind of isolated in terms of interaction because they're because of the, you know, the difficulties that they experience. Young people, and I think that Felipe, the point you make is so important about the people who are not at the center of the conversation, and where, you know, those people are in less powerful positions, and they're the voices we definitely need to be kind of hearing more about. And as you said, in the context of kind of from a decolonial perspective or decolonization perspective.
Thank you, Rose. Any more comment?
I mean, you might say it's a social justice kind of issue, really, I think, for many people, I think. And people talk, and as like Luigi's talking about dignity, Robbie is talking about in the context of people with dementia. I mean, there's various kind of concepts you can use. And as you said, Lisa, yourself, there's all these other kind of concepts that are related. So yeah, it's so important.
No more?
I mean, I can add one final comment, Lisa, which is that there is a strong link between the people who are the more disadvantaged people and the poorer health outcomes. And so, for example, if you took like Luigi's work with people with severe mental illness, they die 20 years earlier than people without that diagnosis. So, I mean, there's huge, important kind of really important like clinical outcomes as well. It's not just a question of like respect or, you know, I mean, which is for us, that's important enough, but there's other arguments as well, strong arguments.
Yeah, good. I think that's a general message of the book, actually, something that Matthew Broom and I discussed in the preface. It's not just being nice, as Elisabetta was saying earlier. It's not just kind of respecting people. It's not just about communication. It's really about good medicine, right? And good health outcomes. So on this note, I should thank all of our participants for bearing with us for 2 hours and posting such good questions in the chat. And I really want to thank all of our panelists for providing such concise and yet rich presentations. And thank you, everybody, for being here today. And there will be a recording, slightly edited recording of this webinar available in a few days. So I'll leave you with this. And just a reminder that the book is available open access, and you can read a lot more about each of these topics in the various chapters of the book. Thank you very much.
Thank you so much.
Thank you, Lisa. Thank you, everyone.
Thank you.
Thank you, ladies, and thank you, everyone. Bye-bye.
Bye.
Bye.